Jayakumar, we can start, I think. Sir is ready.
Shall we start, sir?
Yes.
Good evening, everyone. Welcome to the next session of Professor AD's Virtual Clinics for Postgraduates. And today's session, I'm very happy to welcome our guest speaker, Professor Nalli R. Uvaraj, sir, for the topic on thoracolumbar spine fracture classifications as well as other spinal fractures classification. And Professor Nalli R. Uvaraj is currently the head of the Department of Spine Surgery at Madras Medical College and Rajiv Gandhi Government General Hospital. I'm very happy to welcome you, sir. And sir was the past president of Tamil Nadu Orthopedic Association, as well as he was the immediate past Secretary General of Orthopedic Association of South Indian States. So currently, as like Professor Devadas sir, Nalli R. Uvaraj sir is also very enthusiastic in teaching the postgraduates, and he is the examiner for MS Orth, DNB Orth as well as FNB Ortho, FNB Spine. So I'm very happy to welcome you, sir. And over to you, sir, for starting your presentation.
Jayakumar, am I clear?
Yes, sir. Clear,
should
sir.
I have my headphones? Sir? So this is what I want to know. I'm clear.
This is very clear, sir. Very clear.
Yes. Thank you. Respected Professor AD, Professor A. Devdas, we fondly call him Professor AD. Dr. Satish Devdas, the course coordinator. Dr. S. Jayakumar and Dr. Deepak, the moderators. And my co-host, Dr. Aju Bosco, I think he'll be joining shortly. And my delegates, let me first wish you all a very good evening. I think this evening would be very fruitful to the postgraduates who are going to listen to this session. First of all, I always consider it an honor whenever I get an invitation from IORAS, because this is one place where we see academics. So hence, we always love to be there and then share our knowledge. And I only remember the days when Professor A. Devdas stayed for a short period at the Institute of Child Health, Egmore. So in spite of his difficulties, he used to take class on one day in a week. He used to collect the cases, pediatric orthopedic cases, and he used to show us all the cases. So I cannot forget all those lovely memories when we had lovely cases there. So we used to, all the postgrads used to rush in there to listen to his lectures. And he always had the art of teaching the students. I've been seeing him since I think 1988, when I joined as a D-Ortho candidate at Government Roy Prof Hospital, when he first hosted the IOA Con at Madurai, which is a real grand success. And from that time, I've been seeing him. And one another thing which everyone says is that he looks the same. Like I only would say that he looks the same as what I saw him in 1988. With this small introduction, I would like to go into subject proper. So like today, what I have planned is, so when they asked me to talk on classification of spinal injuries, it's the very, and I need to put it within 1 hour. I don't think it's possible to finish everything there. I'll be just rushing through and then nothing is understood by the postgraduates. So today what I have planned is, what is the recent trend as far as classification is concerned? And I'm going to discuss only the common spinal injuries. The rest you can just, rarely you're going to get these, and you can go and refer the charts which are available in the AO website, and then you can classify them. So I'm going to mainly talk about the AO spine classifications, because that is the order of the day now. So, and I will be concentrating on dorsolalumbar and subaxial cervical spine injuries alone today. So this is going to be very interactive. See, since this is going to be available on YouTube, I only request our postgraduates not to keep jotting down anything. Maybe you can just have short, like important points to be noted down, but don't keep writing everything, because this is, I'm sure it's going to be available on the YouTube. You can just go and listen to them again. But the only thing is, you just concentrate here, and so that you will be able to listen, understand clearly, and then you will be able to answer. We are having a few interactive sessions, and lastly, we also will be having a question, polls session, where you will be able to answer, and let me see how much you people have understood. Okay. Now, so to start with, as I told you, thoracolumbar spine fractures are the most commonest ones which we are going to encounter. And the AO spine classification of thoracolumbar spine fractures had evolved even well before the AO spine classification of cervical spine injuries. So hence we will start, because there's a better understanding of thoracolumbar spine fractures. And even the postgraduates, if you are going to first listen to these thoracolumbar spine fractures, the cervical spine fractures classification also would be very easy. So let me start. How do I take it off screen? Yeah, yes, that's it. Okay. No, the okay.
The camera, sir. You can just.
I'm not, the details about the participants, I want to take it off. Otherwise, it's blocking a part of the presentation. So
Yes, you click on the image and minimize it. So there's hide thumbnail videos there. Video. Or if you go to view, it will say exit full screen. Go to full screen.
So you're talking about the horizontal.
Yeah, that's it. Horizontal.
Yeah. There you just hold that, and you can drag it to the top or bottom. There'll be a green color.
I know, but I want to totally put it off. Is it possible?
You can put it to the top. It will hide.
Okay. Because the part of the slide it is blocking. That's a problem. Okay. Now the thoracolumbar junction is a transitional zone. What do I mean by transitional zone? Because the thoracic kyphosis becomes a lumbar lordosis, and similarly, there are a lot of mechanical differences occurring. The lumbar spine is less stiff than the thoracic spine, which is more stiffer in flexion. So hence this is a transition zone. As a result of this, this region is predisposed to failure, as the anatomically there is little opportunity for the force dispersion, leading on to central loading of the thoracolumbar junction and leading on to failure. Now there is a lot of controversies as far as the thoracolumbar fractures are concerned, right from the classification which we are going to discuss today. The other controversies being indications for surgery, the optimal time for surgery, and the best approach for surgery. So these are topics by itself. You can talk for one day on each one of them. Now, we are going to today discuss only about the classification. And we need to know that what is the necessity for having a classification. It is mainly needed for a uniform method of description of the injuries. It should help in directing the treatment and also in facilitating outcome analysis. And most importantly, the qualities of a classification are that it should be comprehensive, reproducible, easily usable, and they should be accurate. Now, this is the evolution of the classification of thoracolumbar fractures, right? Starting from 1920, it's been evolving until 205 when we had the Telix classification. But none of the classification systems described thus far has achieved universal acceptance, like as far as the lack of reliability, accuracy, and clinical relevance is concerned. So the universal acceptance is not there. Now, starting with the McAfee classification, these are the things I think you should not need to know about each one of them, but you need not just mug up. You need not even remember this. We will just concentrate on the AO classification. This is for the completion's sake. I'm just go through this. The understanding of the association between the fracture morphology and the stability was provided with McAfee classification and provided much of the intellectual basis for later schemes which use morphology to describe the fracture stability and treatment recommendations. Then came the Magriel classification 1994, and he gave a comprehensive description of the fracture anatomy, which is the basis for the various classifications of late we are using, and was intended to follow a hierarchical system in which successive grades represent increased fracture severity, instability, and consequently inferred increased risk of neurological injury. There are 3 types and 50 subtypes, in fact, of this, broadly divided into compression injuries, flexion extension injuries, and rotational injuries. The merits are that they are very detailed and considers both the fracture pattern and the mechanism. But the disadvantage being it's overly complex, poor reproducibility, and does not account for the clinical status or neurological injury. Then come the Telix classification. This guides us in the management as such, developed by the Spine Trauma Study Group in 2005, where they gave points for the fracture mechanism, then the neurological involvement, and the posterior ligament complex injury. Now, according to this, patients who had a point less than 4 points were treated conservatively, and more than 4 points were treated operatively. So this is how it was to some extent helping us in the management for quite a long time. But the only disadvantage is that the feasibility of evaluating the PLC integrity using magnetic resonance imaging has been questioned. It's highly questioned now, actually. And the chosen severity scoring system guiding treatment may be a culture or regional specific decision and may not reflect a global surgical preference or the most rational approach to treatment. Hence, this fell out of repute and hardly we follow it. Now, there was a combination of the Telix and the AO Magriel classification, what they call as the AO Spine Telix classification in 2013, brought out by the AO Spine Trauma Knowledge Forum combination, combining both these Telix and Magriel classification to produce a comprehensive and simple classification system. And this was that, and still, this is the basis, I should say, for the AO classification, which we are going to discuss today. Now, we coming to the subject, you just forget all those things. Now you can later read in detail as far as for examination concerned. We will just go into the AO spine classification for traumatic fractures of thoracolumbar spine, as these are the common injuries which you come across. So you just concentrate here carefully, and then you'll be able to understand very easily. Now, thoracolumbar fracture class AO classification is based on the evaluation of 3 basic parameters. One is the morphological classification of the fracture, the morphology of the fracture. Number 2, the neurological injury, and the clinical modifiers. There are 3 things you got to keep in mind. So I will be discussing about each one of them, the morphology, the neurological injury, and the clinical modifiers. I'll be explaining to you all about each one of them. The morphological classification, this is based on the Magriel classification modified by the AO spine classification group. For this evaluation, you need to have a good radiographs. CT scan is a must with multiple reconstructions, and in some cases, additional MR images may be necessary. Based upon this evaluation, we can divide them into 3 basic types on the basis of the mode of failure of the spinal column. It is type A, which are compression injuries with intact tension band. What I mean is the tension band is you have an anterior tension band here, the ligaments here, and the posterior tension band here. So both the anterior and the posterior tension bands are intact, and you have compression injuries. These are type A injuries. Type B injuries, it's failure of the posterior or the anterior tension band through distraction. So here, the first one, type A, there is no failure of the tension band, whereas in type B, there's a failure of either the anterior or the posterior, and this can occur only by distraction. And the alignment of the spinal axis is maintained, very important. That's very, very important. This is what is going to differentiate between a type B and a type C. So the alignment of the spinal axis is maintained without any signs of translation or dislocation. And type C is any failure of all the elements leading to dislocation, translation, or displacement in any plane. If you see a displacement, blindly say it is type C. So type A, you do not have a failure of the tension band, intact tension band, with just a failure of the anterior column and compression injuries alone. Type B is where you have a failure of the anterior and the posterior tension band. Type C is where you have a displacement, translocation, or dislocation, everything. Now, type A is subdivided now into A0, A1, 2, 3, and 4. We'll go one by one now. A0, first starting with A0, these are minor non-structural fractures. Like, for example, it may be a fracture of the transverse process alone, or a fracture of the spinous process alone. So these, you should remember that these will not compromise the structural integrity of the spinal column. So these are minor non-structural fractures, what is known as A0. A1 is a wedge compression fracture. It's a fracture of the single end plate. It could be superior or inferior. With most important thing is without involvement of the posterior wall of the vertebral body. Very important. You can just have a look at here. You can look at here. And very important, you should have an axial section of the CT spine and rule out a failure of the posterior wall of the vertebral body. Here you can again see there is no failure there. So a simple compression fracture, what is known as A1 fracture without involvement of the posterior wall of the vertebral body. Now, A2 is a split fracture, a fracture of both the end plates. It extending from both the end plates. Here again, without involvement of the posterior wall of the vertebral column. You can see here it's not involved here. It is not involved here, but there's a split here. The split extending to both the end plates. This is known as A2. A2 is a split fracture. Remember that A2 is a split fracture. A3. A3 is an incomplete burst fracture. Here again, it could be either a superior or the inferior end plane. So fracture with any involvement of the posterior wall. In A1, there is no posterior wall involvement. Remember, that's why we call it A1, though there's a failure of the anterior column. Whereas in A3, there is involvement of the posterior wall. Only a single end plate is fractured. And vertical fractures of the lamina are usually present and does not constitute tension band failure. If you, along with these, if you see a fracture of the lamina like this here, don't call them this failure of the tension band. So here you can see that here, the superior end plate alone has been affected and the posterior wall has been affected. So this is A3. This is a incomplete burst fracture. Then comes the complete burst fracture. Here, the fracture involvement of both the posterior wall as well as both the end plates. So the diagram is very self-explanatory. You can see that. And the vertical fracture lamina are again usually present in these cases, and these do not constitute a tension band failure. So that is not of any significance at all. Okay, so these are the A4 fractures. So we have seen the type A fractures starting from A0, which are insignificant fractures of transverse process, the spinous process. A1 is a compression fracture without involvement of the posterior wall. A2 is a split fracture. A3 is a fracture of one end plate alone with involvement of the posterior wall. That is incomplete burst fracture. A4 is a complete burst fracture involving both the end plates there. So this is regarding type A. So now type B now. Type B is failure of either the anterior or the posterior tension band through distraction. So the tension bands can be ruptured only by distraction forces. But the very important thing that differentiates from type C is that the alignment of the spinal axis is maintained without any signs of translation or dislocation. If there is a failure of these tension band along with the displacement or a translation, it becomes type C. Just remember that. Now, here again, the subtypes of type B are type B1 is a transosseous tension band disruption. Here, there's a distraction force acting posteriorly. And you can see the failure of the posterior or trans is a monosegmental pure osseous failure of the posterior tension band. It's not involving the ligaments at all here. This is a pure osseous one, and this extends into the body. It just extends into the body only. So this is what we call as a classical chance fracture. B1 is a chance fracture, which is a transosseous tension band disruption. B2 is, it could be a bony, like here, bony, or a ligamental disruption of the posterior tension band together with a type A fracture. Any combination it can be. So type A fracture has to be combined with the posterior tension band, what you call as a B2 fractures. Okay. So you got described type A fracture when we are classifying them, which we'll be telling you all later. For example, here, if you see here, there's a fracture of the osseous failure of the posterior tension band with a complete burst fracture here. So this would be this should be classified as, this is a T12L1 level, T12L1 B2 fracture, because it's a transosseous combined with the type A fracture. So with the T12 being a A4 according to the combination rules. So you slowly, as you can, it may be a little overtaxing for you, but you will be able to pick it up later. Now, then the B3 injuries are hyperextension injuries. So the other two, B1 and B2, are flexion injuries, whereas the B3 is a hyperextension injury. So here the injury is through either the disc or the vertebral body, leading to hyperextended position of the spinal column. And this is very commonly seen in ankylotic disorders. So the anterior structure, especially the anterior longitudinal ligament, are ruptured, but there is a posterior hinge preventing further displacement. It will not be displaced. Very, very important. You got to see whether if it's going to displace again, it becomes type C injury. So this is what happens. It could be either failure through the body of the vertebrae, or it could be through the disc also. So very commonly seen in ankylotic disorders like ankyloid spondylitis or various spinal stiffening conditions. So that is typical B3. You just remember this. Typical B3 hyperextension injuries are very common in the stiff spine. Now the type C, any displacement, it could be either a forward, sidewards, or subluxations. So any displacement or dislocation, you call it type C. There are no subtypes for this. Okay. So there are no subtypes as because the dissociation between the cranial and the caudal segments, various configurations of possible different images, and is combined with subtypes of A if necessary. So later we'll be discussing about that. So this is in short about the type A, B, and C. So this is the algorithm. For want of time, I'm not going to go into them. Now, the second point that has to be taken into consideration, one is the morphology is over now. Second is the neurology. So you have got to describe all three, putting all three together. The neurological status, as you can see it here, is from N0, N1, N2, N3, N4, and NX. Okay, N0 is neurologically intact. N1 is transient neurologic deficit, which is no longer present. So they had a deficit and they recovered now. N2 is a radicular symptoms. N3 is incomplete spinal cord injury or any degree of cauda icona injury. N4 is a complete spinal cord injury. And NX is where the neurologic state is unknown due to sedation or head injury. So this is what is meant by the neurological injury from N0 to N4 and NX. Now, third factor which has to be taken into consideration is the modifiers. There are two modifiers which can be used in addition to 1 and 2. The modifiers are M1 is, this modifier is used to designate fractures with an indeterminate injury to the tension band. So you're not very sure about the tension band injury based on spinal imaging with or without MRI. So this modifier is important for designating those injuries with stable injuries from a bony standpoint for which ligamentous insufficiency may determine whether operative stabilization is a consideration. So M4, like you got to, suppose you are not very sure about the posterior ligament complex injury, then you can just put it as M1. And then M2 is used to designate a patient-specific comorbidity which might argue either for or against surgery. That's like, for example, there are any contraindications for surgery. Like, for example, it could be an ankylosing spondylitis, or there may be burns affecting the skin over the injured spine, or the extensive scarring of the posterior skin. So all these things in such situations, you can put it as M2, where you are finding it difficult to normally operate on these patients. So M1 and M2 modifiers. So the case-specific modifiers would not be relevant to every case, and only when they're there, you got to mention them. You need not mention in all the cases. That's what they mean by this. Now, how to code these now? So now you know A, B, and C. How are you going to code them? And then you have the neurology, and then you have the modifiers. So in coding, you should remember that type A injuries affects either a single vertebrae or occur in combination with type B or C injuries. So what type A injury is there? But preferably the type A is involving only one single vertebrae. Similarly, B1 injuries, that is a transosseous, pure transosseous failure, is a B1 is affecting a single vertebral body. So you got to just mention only that body alone. And hence type A and B1 injuries are coded by the single vertebral level. Say, for example, it's D12 or L1. So you got to mention that it is a type A, L1 type B1. Similarly, with D12 type B1, like that. So we'll be seeing that slowly, like you'll be able to pick it up. Now, rest, like starting from B2, B3, and type C injuries, affect at least one motion segment. So 2 vertebrae will be involved. That's what we mean by the motion segment there. And these injuries are coded according to the affected segment. It could be D12L1 or L1L2 or D11T12, like that. So these are multi-level injuries, should be classified separately and listed according to the declining severity. And when injuries of same subtype are present, the injuries will be described in order of cranial to caudal direction. So supposing you have 2 injuries, 2 contiguous injuries, D10, 9, 10, or then you have D12, L1. Then you got to first mention the upper D9, D10, and then the D12, L1, like that. And finally, how should you mention this? It might look very difficult, but as repeatedly, if you're going to see this, it becomes very easy. So how the classification nomenclature, like for example, if this is going to be a C6, C7 translational injury, you will call it a C type injury. That's a primary injury. So that's what I mean by here. C6, 7 primary injury. And then you got a secondary injury. If you have a compression fracture of the C7, then you call it C7. Compression is A1. The posterior vertebral, wall is not involved. So totally you can put it like C6, 7, C type within brackets, secondary injuries, C7 and A1. Next you go to this will forget it. This will be describing in that cervical spine injury. The next one is the factors, the neurological status and the modifiers. So neurological status, like for example, if it's going to be like this, C6 is on flexion distraction injury. So this is a C6, 7 B2 injury. B2 injury. So with perched facet dislocation. So for we'll come to the cervical spine there now. Supposing you have a neurology there is a transient neurologic deficit, then you can call it radiculopathy is there, you can call it N2, or a transient one, you can call it N1. And as far as the thoracolumbar fractures are concerned, it could be M1 or M2 only. This is the cervical spine, so we'll forget this now. So we'll go to the exercises, you'll be able to understand now. See, this is a fracture in a 40-year-old male, a history of fall from height with a complete neurologic deficit. Has Aju joined now? Has Aju joined? Aju Bosco? Okay. Now, if you remember, I told you that if there is going to be a failure of the most primary injury is a failure of the posterior tension band. There is no displacement, so C is ruled out. It is not purely the anterior column alone, compression fracture alone. So A is ruled out. So only thing which is left is B. Is it B? Yes, there is a failure of the posterior tension band. And then you also have a failure of the anterior column. Can you put this in any one of the type A's? Yes, it can be put as a complete burst fracture, A4. So your primary injury is level is D12 L1, okay, B2. So this is not B1 because it's not a pure osseous one. It's a combination of type A fracture with the posterior tension band failure. So T12 L1, so this is a B2 injury. B2 injury, and then the secondary injury is D12 is A4. So totally put together, and the neurological status, as I told you, this is a complete neurology. If I'm right, no, is it complete? Yeah, complete neurologic deficit. So that becomes N4. So the total thing would be, putting all together, this is a T12 L1 B2 type fracture. The secondary injury is T12 A4, and neurology is N4. So this is one example. We'll go to the next example now. Slowly you can pick it up now. Here now, slowly you will be able to understand as I keep evolving. Showing you the cases. This is a 50-year-old female who had a fall into a pit of 11 feet, and her neurology was normal. So you can just remember this. And now we will go now. So you should find out the primary injury.
Excuse me, sir.
Neurological.
Aju here.
Oh, Aju has joined. Okay.
Yeah,
Aju.
yeah.
Aju, can you this is as you can see from the screen here.
Yes, sir.
This is a 50-year-old female who had this injury. Yeah, tell me.
Yeah, sir.
We were discussing the primary injury, secondary injury, and the neurological status of the modifiers. So what is the primary injury here now?
So the level of injury is L1, and it is a A3 injury, which is a incomplete burst fracture, as the posterior cortex is involved, and there is.
So what I explained to because these are postgraduates. So it is just failed. The only one end plate is failed, and the posterior wall of the body is involved. If it's not if the posterior wall is not involved, then it would become A.
Yeah, it becomes A1.
1.
Yeah, if it is a pincer type, it becomes A2.
Yeah, A2. Yeah, right.
So if we have to say A3, then posterior A3, A4, then posterior wall has to be involved.
Yeah. So this is a primary injury is?
Primary injury is L1, A3, sir, because one end plate is involved and posterior wall is involved.
Perfect. Right. That's it. That's it. So L1 is A3. Okay. Next, what happened?
And there is no secondary injury. There are no secondary injuries. And the neurology.
She's got a normal neurology.
Neurology, if it is normal, it is N0. And if it is an incomplete, it becomes either N3. Sir.
Yeah. Okay. Right. No. Let's see. N2 is a radiculopathy. N3 is a recovered after.
Yes, sir. Yes, sir.
Okay. Now this is it. Next coming to, so putting all together, it should L1, A3 and N3 only. Okay.
Yes, sir.
Now coming to this, this is a 45-year-old male, history of fall into a 30 feet well with complete spinal cord injury.
Yeah, the level, sir, level is, so it is D11, D12, AO type C, the primary injury.
Yeah, so you see a displacement there. As soon as you see a displacement, you will put as type C. Okay, type C.
Sir, the translational injury.
Yeah.
And the secondary injury is, there is at D12, there is an A4, A4 fracture, yes.
Yeah, this is the second. You can see the MRI, which also shows the involvement of the inferior end plate also.
Yes, sir. Yes.
So it is A4 fracture. That's it. Okay, so D12 is A4. That is secondary injury. The neurological status is complete neurology.
So it becomes N4. Sir.
Yes, that's it. N4. Okay, so putting all together, this is D11, D12, being a primary injury C. D12 is A4 because it's a complete burst fracture, and with N4, it's complete neurology.
Yes, sir.
So this is how it goes. So this is see, as you repeatedly see these videos, now you'll be able to pick it up. Okay, so to conclude, there is no universally accepted classification of thoracolumbar fracture so far to guide the treatment, and the AO spine thoracolumbar classification system should be able to guide the treatment and predict the outcome to overcome pitfalls of the other classifications. And I will say that this is going to be the order of the day. Like slowly, like all the rest of the classifications will get obsolete, and then we are going to follow this classification only because it's catching up very fast in the spine world and classifying thoracolumbar fractures with the AO spine fractures. Our clinical experience, clinical scenario should not be overrated by these classification systems to guide the treatment. So to some extent, you will be able to follow these and use them for guiding the treatment. But certain situations, you might have to use your clinical judgment in deciding the management of these fractures. So this is regarding thoracolumbar fractures. Now, coming to the next one now. So if you have a good knowledge about this thoracolumbar fractures, then cervical spine fracture classification becomes easier. I'll show you how does it differ from the cervical, thoracolumbar fractures. So what are the challenges in the development of comprehensive classification for cervical spine is that because of the complex anatomy of the cervical spine, and there's a wide spectrum of injuries, and there's disagreement in injury morphology between clinicians, and a cumbersome during communication. So these are the various classifications of cervical spine injury. I'm not going to detail about each one of them. Right from 1982, they've been struggling to have a good classification, and then the AO classification is what we are going to discuss now. And these most are based on the mechanism of injury, and hence you can just go into detail about all these. You read it by yourself. But we'll go to the AO classification for want of time. Now the AO classification subaxial cervical spine injuries is a result of a systematic assessment and revision of the Magritte classification. And this incorporates both the fracture morphology and the clinical factors relevant for clinical decision making. And very importantly, this has been validated by the AO Spine Knowledge Forum. Now, here, these are the criteria used. Like in the thoracolumbar fractures, we saw we used the morphology of the fractures. Then the second one was the neurological status and the case-specific modifiers. In cervical spine, you got to add one more, that the facet injury has been added. And this has to be taken into consideration in classifying these injuries. So the difference between thoracolumbar and the cervical spine is that you have one more added factor that has to be considered as a facetal injury. Of course, the case-specific modifiers are going to vary also. Now, starting from the morphology, there are three basic mechanisms as you have seen in thoracolumbar fractures: the compression injuries, the distraction injuries, where there is a failure of the anterior or the posterior tension band, and when you have a displacement or translation, we call it a type C. Of course, type A is a compression injury of the anterior column with intact tension band, both anterior and posterior. So this you know that, I think, from what we learned last time. So the subtypes of type A are here again. We start from A0. Here there are either there is no bone injury or isolated fractures of the lamina or the spinous process fractures. And a central cord syndrome without an associated fracture can also put in this A0 type. Now, the other type A injuries are subtype A1. Here again, it's a compression fracture without involvement of the single end plate, without involvement of the posterior wall of the vertebral body, same as what we saw in thoracolumbar injuries. And type 2 is a split fracture, coronal split or a pincer fractures involving both the end plates without involvement of the posterior aspect of the vertebral wall again. Then type A3 is, once again, burst fracture involving a single end plate. And these injuries affect a single end plate, resulting in bony retropercussion without any involvement of the posterior vertebral wall. No, you got involvement. There's involvement of the posterior vertebral wall. Type A4 is a complete burst fracture. Okay, or a sagittal split, as you can see here, or a sagittal split is also brought under A4, involving both the end plates. And these injuries are similar to A3 injuries, but involve both the end plates. That's the difference here now. So this is regarding A0 to A4 in type A. Now, type B injuries, again, as I told you, there's a failure of the tension band, which can be either an anterior or a posterior. So we always start from posterior. As you can see here now, it's a posterior. A B1 is a posterior bony tension band injury. You can see a pure bony one here now. So the primary physical separation through the fractured bony structures only, and these injuries are failures of the posterior tension band extending into the vertebral body. That is it. So the anterior structures as a vertebral body or disc may also be involved and should be specified separately. So B1 injuries. B2, as I told you, similarly again here now, there's a complete disruption or separation of the posterior capsule ligamentous or bony capsule ligamentous. It could be a combination of both the bony or a ligamentous one. And the anterior structures may also be involved, should be specified separately. As we saw in the previous one, we got to specify what type of involvement is there in the anterior column. B3 is an anterior tension band injury, similar to that what we saw in thoracolumbar injuries. So once again, there's a physical disruption or separation of the anterior structures. It could be either a bony or a disc with tethering of the posterior elements. And these injuries may pass through either the intervertebral disc or through the vertebral body itself, and very common in the ankylosing spine, same as that in the thoracolumbar injuries. An intact posterior hinge will prevent a gross release. Once you have a displacement here, it becomes type C injury. So there is no displacement also here. Some hinges there to maintain the alignment. type C injuries, again, as I told you, the translation injuries, injuries with displacement or translation of one vertebra related to another in any direction, and any associated injury, either a type A or type B injury, should be specified separately as a subtype after designation as a type C injury. So describe first the primary injury, and then you got to describe the secondary injuries also. And injuries where the anterior and the posterior vertebral elements are distracted would be classified as a translation injuries again. So this is type C injuries. So we'll finish the morphology now, and then we will go to the next one now. So of course, just remember, we'll be talking about the facetal injuries now. So we will first start with the facetal injury now. Facetal injury, like you just remember, need not go in depth. F1 injuries are where there's undisplaced, non-displaced facet fractures. F1 injuries are where if you see a displacement there, then they are potential for instability. So they are F2 injuries. Then if it's going to be this is a peculiar type, the F3 injury, where it's a floating lateral mass, we can remember it. So it's not only a fracture of the lamina, but also fracture through the pedicles. So these are floating lateral mass injuries. So F3 are floating lateral mass. F4 injuries are whenever you have a pathological subluxation or perched facets or dislocated facets, you put them as L4. So if it's going to be involving both sides, then you got to put it as bilateral here now. So bilateral modifier used when the same type of facet injury is observed, bilateral in the sternum vertebrae. So one more thing we added is the facet injury has been brought in apart from the morphological classification. So we finished all these things now. Now comes the neurological status as we saw in the thoracolumbar injuries. Here again, you can see that it's the same. N0 is neurology intact. N1 is transient neurologic deficit. N2 is radicular symptoms present. N3 is incomplete spinal cord injury or any degree of cauda injury. N4 is complete spinal cord injury, and NX is you are not able to examine, you are not able to determine what injury is there. And lastly, plus, you can add plus, which shows continued spinal cord compression, which we'll show an example here now. So if it's going to be continued spine, you see that there's you're able to nicely see the continued spinal cord compression, then you can call it as plus. You can add plus to that. And the case specific modifiers are there. We had just 2 there, but here there are 4 here, M1, M2, M3, and M4. M1 is where you have identified by an MRI that there's a posterior capsular ligamentous complex injury without complete disruption at all. You have some doubts about it, you can put it as M1. M2 is a critical disc herniation. A lot of times you'll see that there is a disc which has herniated and it is pressing on spinal cord. You cannot go and treat them posteriorly. You got to go and deal them anteriorly, remove the disc first, and then only you're going to go for whatever management you're going to make. So the critical disc herniation, if it is present there, you got to mention M2. M3 is stiffening or metabolic, any stiffening conditions of the spine. It could be a dish or angular spondylitis. All these things you got to put as M3. And M4 is when there's a presence of vertebral artery anomaly, you will have to. So very important thing, because vertebral artery anomalies can be a life-threatening one if you're not going to miss them, if you're going to miss them, especially in the upper levels. So the M4 vertebral artery anomaly, if they are present, you got to be very careful. Probably you might have to avoid that level, the opposite level, and involve management with will be varying depending upon the what type of anomaly is there, because you should not jeopardize the only problem. Supposing there's only one vertebral artery there, you cannot go and jeopardize them. So this M4 is a vertebral artery anomaly. Now this is the algorithm. Again, I don't want to waste my time here. This is what I want to tell you here now. So this is a cervical spine injury here. If it's going to be a C6-7 flexion distraction injury, you can put it as B3. And then perch facet means F4 on the right side. And on the left side, if it is going to be F2, then F2 is there. And then neurology, if the radiculopathy, it is N2. And if the modifies, supposing it's in the case of ankylosing spondylitis, you got to put it as M3. This is how you the classification nomenclature comes, which you will understand now as I keep going. Now, Aju, can we start here now?
Yes, sir.
Case 1, 25-year-old male, high-speed motor vehicle accident, and he had a complete spinal cord injury. So can you say something about this?
Yes, sir. This is a sagittal CT scan showing a translational injury at C7 T1 level.
Yes. So you see the displacement that immediately forget about A and B. Straight away to C-type injury. Yes.
Yes. And then at T1, we can also see a compression fracture. The posterior cortex is still intact. So it becomes T1 A1. That will be the secondary injury.
That's it. Yeah. T1 A1.
Yes,
and
sir.
then?
And then there is a C5 over C6, no, sorry, C7 over T1 facet dislocation. Since you have given it as bilateral, we have to put F4 and yes, sir, F4 and BL. And
any dislocation of perched or subluxation, you got to put as F4, and if it's going to press on both sides, you got to add the BL by that.
Yes, sir. And
Okay.
since it is a complete spinal cord injury, it will be N4. N4, sir. It's a complete spinal cord injury, it will be N4.
So this is how we put it here now. So T1 is second injury is A1, bilateral F4 facial injury with neurology N4. So yes, this is how it goes. Okay, this one now. A 42-year-old male, high-speed motor vehicle accident. He had a right-sided brachialgia and weakness in the C5 and C6 myotomes and numbness of the right C5 and C6 levels. So how will you put it now?
So this is
so what's the primary? Is there a primary injury?
There is no primary injury, sir. There are
not there. Okay, yeah.
Yeah, there are facet injuries.
Yeah, you straight away. Only thing that is you are able to see is facet injury. So now you should know it's very important that you have the parasagittal sections and then have a look at the facets on both sides. It's not just you'll see a mid-sagittal section and then you will come. See, if you're going to see this CT there in the first CT, you'll say it's a normal injury. So whereas if you go and see the parasagittal sections, you'll be able to see the fractures of the facet joint. Yes, you can carry on.
So at C6, we have a F2 type of facet injury. F2 means the facet injury, the lateral mass, less than 40% of lateral mass is involved. Sorry, more than 40% of lateral mass is involved, but it is at a critical position. Here, it can lead to a future dislocation. So
I just taught them just displaced facial fracture.
Yes, sir.
You can see that the displacement occurring there now. Then what else you see? That is C6 level. Then
and also at C5, the level above, we can see a small facet fracture, which is F1. Sir. It can be F1. Yes.
F1. That's it. Yeah. Okay. Right. So this is how it goes. And then.
And since it is mentioned right brachialgia and weakness, it will be probably N2, sir. N2 should be N2.
Yeah, N2. That's right. And then doing an MRI, they found that discoligamentous injuries. I mean, the ligament injuries posteriorly. So that would make it
M1, sir.
M1 modifiers. Yeah, that's it. So that's the final one. So C6 is F2, C5 is F1, neurology is N2, and M1 modifier because of the posterior capsule ligamentous complex injury. So this is one. Now this one here. Second case.
This is a C6.
69-year-old male sustained injury to fall of weight on the head, and he has got no weakness or numbness of the limbs. So normal neurology. Okay. So how will you describe this?
So X-ray shows a C6, C7 facet dislocation, which is type C. That will be the primary injury.
Yeah, you can first is the displacement is there.
Yes, sir. Okay. So straight away it goes to type C.
Yes.
And on the CT scan, we can see that there is a compression fracture at C7. Secondary
injury. What type is it?
A1, sir.
A1. Okay. Fine. C7 is A1.
Yes, then? Sir. And also there is a right facet. There is a facet dislocation, C6 over C7. So that becomes F4.
F4.
And on the left side, the left facet is not dislocated, so it is only unilateral. So F4, just F4.
Yeah, it's going to be, that is also going to be displaced. Then you got you got to put as bilateral. You got to add BL there. Okay.
And yes, sir. And there is no weakness or numbness of limbs. So neurology will be N0.
N0. Okay.
And so that's
the final. That is the classification nomenclature. So yes, C67C, C7 A1 secondary injury with the facet F4 type of injury and with the normal neurology.
Yes,
so this is how it goes. So one more example we'll see now.
So
Case 4, 25-year-old male fall from height. He had numbness and weakness over the right C5 and C6 dermatomes.
So 2, 3, 4, 5, 6. So it is a C6 split A2 type fracture will be the primary injury, sir.
Yes.
And there is also in the CT axial cut, there is a fracture of the lamina, which will be A0, insignificant fracture. But whenever we have,
about it, yeah, we do not
we only consider the highest level of injury.
Yeah. Then,
and also there is on the left facet there is a perched facet C5 C6, so that becomes F4. C5 C6 F4 will be the secondary injury.
Yeah. Then,
and there is the neurology is
actually,
N2.
the interesting thing was it mentioned this as radiculopathy only, no?
Yes, sir.
Radiculopathy. So we should put it actually as
N2.
neurology.
N2, sir. N2.
Okay.
And the plus is to signify an ongoing neural compression.
Yeah, doing an MRI, you can see there's a compression there, continued spinal cord compression. So that makes this plus there. So this is the nomenclature. Okay?
Yes, sir.
Yeah. Okay. Thank you, Arjun.
Yes.
One more case. I think, yeah, there's a one. This 41-year-old male, a trivial fall at home with a complete spinal cord injury. So you can just tell us what you see there.
So this is a B3 type of injury, which is a failure of the anterior tension band.
Yeah, anterior, you can see that there, the anterior tension band has failed.
And since it is a complete spinal cord injury, it will be N0.
Yes. N4.
And N4, sorry, sir. N4. And sir, I don't know, sir. Is it usually it occurs in a diffuse idiopathic hyperostosis or ankylosing? Is it an ankylosed patient?
This is in a stiff spine.
Okay.
So then the modifier would be
M3, sir.
Yeah, that's it. So ankylosed spine there. Okay, right.
Yes.
That's it. Then so that is the complete nomenclature. So thank you, Arju. Yeah.
Thank
you.
So
the advantages of the AO spine classification, both thoracolumbar as a cervical spine, are that a comprehensive yet simple system. See, it might look a little complicated for you, but if you're going to repeatedly see this video, YouTube video, you are going to become master in the classification of AO's classification of spinal injuries. And there's a high intra-observer reliability and reproducibility, and a high inter-observer agreement, and highly useful for communicating as well as for clinical and research purposes. So the advantage of AO spine. That's it. Yeah. So are we going to the poll questions, which are going to be very simple? I made it very simple now. How are we going to go about this? Can I start the first question?
Yes. Yes, sir. Yes, sir. Yes, sir. You can start the questions, sir.
Yeah. The poll first question is, just tell me the type of injury.
The attendees can type in your answers in the Q&A box.
There it is. Yeah.
The poll question.
Shall I go to the answer? Or we'll wait for some time?
So only 9 people have voted, so we'll just wait for some.
Yes, sir. 50% of them have answered type B1.
Great. Yeah, I think at least 50% have understood.
Yes.
Okay. Great. So that's it. The answer is it's a type B1 injury. It's a monosegment, pure osseous failure of the posterior tension band, what you call as a chance fracture. Now the poll question 2. We'll go to the poll question number 2. Can you just tell me the, this is a 50-year-old female, fall into a pit of 11 feet, neurology was normal. So what is the type of injury?
More than 50% have answered correctly, sir. A3.
More than 50%. Yeah, I'm happy actually. Good. It's good actually. So answer is A3 only, right? So here you can see the incomplete burst. You can see the inferior end plate which is intact there. So the inferior end plate is intact. So that if it's going to be complete one, it's A4, no? So if they involving both the end plates, it would become A4. It's involving only the upper end plate alone. So incomplete burst, only single end plate is fractured. With the involvement of the posterior wall, very, very important. You can see the posterior wall involvement here. If it is not involved, then it becomes what? A1. Okay, if it's not involved, it becomes A1. Okay. We'll go to the next one now. Next poll question. Yeah. So here, 31-year male fall from a tree, neurology, incomplete neurology. And we are just asked, the question is what facet type of injury is there? What type of facet injury is there? It's very clear. C560 type of injury is there. So what is the facetal injury type? I'm not asking the entire nomenclature or the entire classification. Just tell me what type of facetal injury is there.
Yes, sir. That's 60% have answered.
Understood. Yeah. Any dislocation, any subluxation, any translocation, anything, no, it's a type F4. Good. The good answer. Okay, fine. So that's it. So as you all know, primary injury is definitely type C. And the answer is F4. It's a pathological subluxation or perched or dislocated facet. We call it F4 injury. Okay. Next one. Now here, what is the primary type? 39 years old male sustained injury to the neck due to trivial fall at home. Complete spinal column or examine spinal column is stiff. Stiff itself, immediately it should caution you about something. Stiff spine. So what a type of primary injury? Great. Very good. So they are really understood, really. So any stiff spine, it's a B3 injury, extension type of injury with the failure of the anterior tension band. Very good. So that's it. Answer is B through anti-tension band injury, which is very common in the stiff spine only. And here, if you see the neurology is complete, no, so that's why it is N4. So the primary injury C56B3, neurology was N4, complete neurology, and ankylosing the modifier is M3. So that's it. Okay, the last question here now. So this is very clear. This is a type C injury, C56 type C injury. That's not the question here now. What is the type of secondary injury? So otherwise, I can describe the radiology findings as a C5 teardrop fracture. The translation of C-type injury. So teardrop fracture, where does it come under? You got to describe the secondary injury, no, of that body of the body. What is that? I'll give a small clue. It's involving both end plates. Good. I thought people are going to get confused.
Yeah, they've understood the concepts.
Yeah, that's good. I think if they're going to repeatedly see this video, they're going to be masters. So the answer is both the end plates fracture of both end plates are there with a coronal plane fracture. That's typical of a A2 fracture. So this would be a C5-6 type C injury with a C5 A2 injury. And then you got to add the neurology, the modifiers, all these things. Okay. So that's it.
Thank you very much, sir, for this wonderful presentation. It was really a nice presentation about the classification systems, and it was really interactive, and hope the attendees, I think they have understood the concept very well. I thank Dr. Raju Bosco also for joining us for this session. And thank you very much, Dr. Raju Bosco. In between your duties, you have come to this session. There are a few questions, sir. Shall we take it now?
Yeah, yes.
The first question is, how do you give the nomenclature if there is 2 or more level instability with fractures?
Yeah, I think I told about this in the initial part of the presentation. Depending upon from the higher level, like caudal to cranial to caudal, you got to say. So I told you, if it's going to be a D9-10 injury along with the D12-L1 injury. So first mention about the D9-10 and then come to the D12-L1. Okay. Cranial to caudal, and in that order it has to come.
Okay. And the next question, sir. What are the various radiological parameters that are to be assessed in a cervical spine X-ray?
I think that is a topic by itself. I think let us not go into details about the various lines which are available there. I think all those things were used to classify them. But here, if you are going to follow this classification, it has been made very simpler. So you got to know whether it's a type C or if it's going to type A or B. That's it. Rule it out. Suppose there is a break in the lines there, that is type C. That's it. So that is it's going to only useful for that. So I think there are various lines available. You can use them to determine whether it is C or the other two types.
Okay.
So for want of time, I'm not going into details about all those lines in there.
Okay, sir. Okay, sir. So, and one more question is, sir, what is tension band? Rupesh from Madurai.
Yeah, tension band is the stabilizing structures which are present both anteriorly and the posteriorly. The anteriorly are the anterior longitudinal ligaments, and the posterior are the ligament complex posteriorly which are present there. The supraspinous and the interspinous ligaments, including the spinous process also, which is part of the tension band.
Okay. Well taken, sir. Understood, sir. And one more question, sir. Skivora, do we classify here? Skivora concept does it come in the
I told A0 I put it, type of injury.
Okay.
You go to the lecture, go back and see that A0 is a skivora, no bony injury there. And then you got to mention about the neurology as well as the modifiers there.
Okay. And another question, what is the word pincer with respect to vertebra? That is the pincer fractures of the vertebra. That is superior and inferior end plate, vertical fracture of.
Yeah, actually, pincer is nothing but the split fracture. Yeah, that is A2.
A2 injuries. Yeah.
Okay.
Okay, sir. Okay, sir. Understood, sir. So I think that is all the questions, sir. Thank you very much, sir. I think the concept was really well explained by you, and all the attendees have understood it well. I request Dr. Satish sir and Professor AD sir to say a few words.
So thank you
Particularly,
again.
I made it a point that I will not go into the details of management. I will just want to stick on the classification alone. And
Yes.
If people, at least more than 50% have understood the classification, it's a very good achievement as
Yes.
far as this lecture is concerned. And
Yes.
with the repeatedly, these students who are going to see them, they clearly understand this concept.
Yes, sir. Yes. Thank you so much, sir. It was actually, you have made that presentation so easy for managing it, basically. So with respect to management, the classification you have told, that is more important, I think. Thank you so much, sir. It was very explanatory, and also the case scenarios discussed by Dr. Aju, as well as the polling, was very interesting and very nice, sir. Thank you so much for sharing your teaching with us, sir. Thank you so much for coming again.
Thank you, Satish. Professor
Thank you,
Devadas?
sir.
Professor Devadas?
I think he's
okay. Anyway, yeah.
Okay.
Right, no problem.
Okay, sir. Thank you again, sir. Thank you very much.
So thank you, Jaykumar. Aju, thank you.
Thank you very much.
Thank you, Jaikma. Thank you, Satish sir. Thank you, sir.
Thank you. Thank you.
Yeah. And Jaikma, you can announce next week's.
Yeah, so the topic for next session is by Dr. Tirmalai Shami. It is about fractures of pelvis and acetabulum, and the case scenario discussion, which will be on next Tuesday, that is 22nd of June.
Thank you. Good night, everyone.
Thank you.